transitioning from oral drugs to intravenous drugs, right? And we've touched on the IOs, right? The other intravenous drug that has positive phase 3 data is Ramucirumab, right? Monoclonal antibody to the VEGF receptor. It's currently approved in several indications, lung cancer, I think gastric cancer. And can you comment on the development of Ramucirumab in liver cancer and where it is today?
Sure. So the VEGF receptor 2 is thought to be a valid target in liver cancer, right? So there was an initial study that was done kind of second line, post-sorafenib, comparing Ramucirumab to best supportive care, called the REACH trial, which was negative. On a subgroup analysis, an exploratory analysis retrospectively done, showed that there was a benefit that seemed to be a benefit in the patient with elevated AFP above 400. So based on that data, the REACH-2 study was done, which limited eligibility to patients who had progressed on sorafenib, had an AFP at 400 or higher, and well-preserved liver function. And that was a positive trial, showing an improvement in overall survival with Ramucirumab compared to best supportive care. Now, one could look at this and say the magnitude of the benefit may have been a bit smaller compared to the other second-line studies, I think about 1.5 months or so. There was a combined analysis then done of both REACH trials, REACH-1 and REACH-2, and taking patients with an AFP over 400. And when that analysis is done, then the magnitude of the benefit is more comparable to what we see in the other post-sorafenib studies at around 3 months or so.
I mean, this is the first time that we have a biomarker to guide treatment in liver cancer, right? We were just talking about PD-1, a biomarker, biomarkers for the TKIs. So now we have a drug that's very specific. It's a monoclonal antibody. We see that it improves survival in the selected group. Where do you see this drug falling into the paradigm now of IO, TKIs, RAM?
Yeah, it's difficult to guess where it will fall, but it's another option, it's another tool we have. I think the safety profile is certainly different than the TKIs, which is a distinguishing factor. So the traditional problems of hand-foot skin reaction and diarrhea are not necessarily there. Of course, hypertension is still there. There were slightly more frequent ascites with Ramucirumab, for example. But generally, the safety profile may be a distinguishing factor as far as an option other than IO for this patient population.
Yeah. And as we talked about the other phase 3 studies, it met its primary endpoint, and secondary endpoints were also improved with Ramucirumab, doubling of PFS and tumor control rates. And how do you think of high AFP, even from your frontline population? Do you start thinking about that right away as a different type of liver cancer?
Absolutely. I mean, I think...
And I'm sorry to interrupt, Anthony. And when I say high AFP, what is high AFP? Out of the normal range? We know in REACH it was 400 as a cutoff. What about 200s? What about 10,000?
Sure. I mean, I think generally it is accepted in HCC in both patients who undergo local regional therapy or systemic therapy that AFP is a prognostic marker. So higher AFP tends to entail worse prognosis generally. Now, what the magic cutoff is difficult, but most studies have been using 400 as that cutoff. Some studies have used 200. But to me, anybody who's above 200, but certainly above 400, I start thinking that I may be facing a poorer prognosis. And does that change my treatment paradigm? Not necessarily, but I'm a bit more vigilant about switching lines of therapy, about palliating these patients a bit more aggressively, potentially. As far as how it relates to Ramucirumab usage, certainly it was an eligibility criterion, but when we look at the other agents, many of them have had analyses to see whether there is benefit in high AFP and low AFP.
So like specifically, lenvatinib looked at that, regorafenib looked at that. In the second line, regorafenib, cabozantinib.
Exactly. All of these agents have looked at that, and even with nivolumab, the benefit seems to be whether there's elevated AFP or not.
I was going to ask you, so in the PD-1, you've presented that data that the response rate is comparable?
Correct, in abstract form. So I think the benefit tends to be there whether the AFP was high or not. So I think we're going to need a little bit more information to know whether AFP will really change our selection of agents.
Yeah. Very interesting. And I think at this meeting, there's going to be some data presented about, how patients who have a drop in their AFP with Ramucirumab tend to have a better outcome as well.